Welcome to another session of the Coffee Break series of presentations. This presentation will provide a summary overview of the Council on Chiropractic Guidelines and Practice Parameters chapter on the upper extremity best practice recommendations. Here are the team members. As team lead, I will attempt to summarize our findings and hopefully provide for you some take-home points that will be clinically applicable in your practice or teaching. First, I would like to quickly clarify the CCGPP intentions with the Best Practices Project. The main goal was to provide the best literature evidence and, when unavailable, provide expert opinion from our teams, who were comprised of both academic leaders and practitioners. We were not attempting to prescribe which treatments to use, how often to treat, or which technique approach to use. Topics were selected based on the most common disorders seen and most common classifications of treatments used by chiropractors based on the literature. Typical search approaches were used, including searches of electronic databases and hand searches of published literature. Ranking of the literature by our team was based on a weighting scheme. We used standardized and validated instruments. The specifics are available in the full document found at the CCGPP site. Our search strategy provided 1,340 source documents. We then narrowed down this large list using filters in our search and by using the filters provided in the citation software EndNote to arrive at 70 RCTs, 12 guidelines, and 14 systematic reviews. We used the standard hierarchy approach to the literature and focused on primarily systematic reviews and clinical guidelines that focused on evaluation and management. Like all reviews, we included exclusion criteria of conditions not traditionally managed by chiropractors. We started with a broad search, but although there was a wide net cast for all musculoskeletal conditions affecting the upper extremity, the following conditions were the only ones with any literature evidence regarding conservative management. The upper extremity was too broad a topic area with overlap among many conditions so that no conclusions could be drawn. For the shoulder, there was evidence for the following specific conditions: rotator cuff tears, impingement syndrome, instability and labrum tears, and adhesive capsulitis. For the elbow, only lateral epicondylitis had any quality literature available. And for the wrist, only carpal tunnel syndrome had quality evidence. Scoring or rating of the literature using the checklist provided to the CCGPP teams were the AGREE checklist for guidelines and the Scottish Intercollegiate Guidelines Network, or SIGN, for RCTs. The SIGN did not contain a quantitative method for generating a global rating, only a plus, minus, or neutral rating. So we developed several schemes to try to objectify this somewhat subjective approach. In essence, this is an attempt to quantify a qualification approach. You will see throughout the presentation a quality rating after many studies. Higher quality studies accrue higher point values and vice versa. When reviewing the highest rated studies versus the low rated studies, and with group discussion, it turned out that the studies in the range of 75 points or above were considered highly rated, those 50 and above are acceptable, and those below 50 are of concern with regard to quality. Following is an example of scoring for an RCT. The team's mission was to determine one of the following for practitioners. There is neither evidence for or against the use of an examination or management approach, or there's mild or moderate or strong evidence for or against the use of an examination or management approach. Throughout the presentation, you will see our team's grading for various topics. Here's how that translates. Grade A indicates there's strong evidence from relevant studies, and Grade B indicates there's fair evidence. Grade C suggests there's limited evidence, and Grade D indicates no literature recommendation can be made. However, we did use this grading for indicating when expert opinion was given. Shoulder pain in the general population has been reported as high as 50% in some countries. The range is between about 20 to 50%, with a prevalence of about 19 to 31% for 1 month, 5 to 47% for 1-year prevalence, and 7 to 67% for lifetime prevalence. Well, why the wide variations? Much of it has to do with whether shoulder pain is taken alone as an entity or combined with neck pain. Chronic shoulder pain is common. At 6 months following initial evaluation, 34 to 79% of patients report still having shoulder symptoms. 24% to 61% report pain 6 to 18 months beyond the initial 6-month follow-up. Most disturbing is that only about half of the elderly who reported having shoulder symptoms actually sought treatment. A prognostic study by Thomas et al. In 2005 indicated that baseline characteristics, not the treatment rendered, were better predictors of outcome. In the Lagacha study, at the time of entry into the primary author's office, an orthopedist, 87% of patients were unable to sleep on the affected side, and 71% were unable to wash the back of the opposite shoulder. Instability seemed to present early, around age 20 to 35. There seemed to be a sequence. Patients with full thickness tears presented 15 years later than those with partial cuff tears. Those individuals with cuff tear arthropathy presented 13 years later than full thickness tears, and the conditions with greatest female prevalence were rheumatoid arthritis and adhesive capsulitis. All other conditions were male predominant. Here's a graph which represents this age relationship. AMBRI is an acronym for atraumatic, multidirectional, bilateral instability due to being born loose, meaning it's due to inherently loose connective tissue. And TUBS is an acronym for traumatic, unilateral, related to Bankart lesions, often surgically corrected. Now, both are forms of instability, and you can see the peak at an early age. Also, you can see the peak around age 40 to 60 for frozen shoulder and the later life peaks for cuff tears and osteoarthritis. Shoulder pain, like low back pain, is being recognized as an enigmatic complaint in that the source of pain and location of pain are not logically manifested as standard clinical presentations. In the search for shoulder pain studies, it became apparent that although there may be a condition focus of a given study, there were often overlaps. This ambiguity is likely a reflection of the coexistence of many conditions, for example, instability and labrum tears or impingement and rotator cuff tears, but also it reflects the diagnostic difficulty of pinpointing the pain source. The team focused on several important guidelines: the Philadelphia Panel Evidence-Based Clinical Practice Guidelines, the New Zealand Guidelines for the shoulder, the Australian Guidelines, and the American Academy of Orthopedic Surgeons Clinical Guidelines for shoulder pain. So, are there any predictors of risk for shoulder pain? Miranda et al. Found an association for increased risk of shoulder pain and mental stress, obesity, and older age, as well as physically strenuous work and working with the trunk forward flexed or with the hand above the shoulder level. There is a risk of chronic shoulder pain that can be identified through psychological predictors. There was an association between a low level of job control and shoulder pain. Leclerc et al., after adjustment for other risk factors, found that the presence of depressive symptoms was able to predict occurrence of shoulder pain. Knowing this, we should screen our patients with a depression questionnaire, or at the very least, ask about feeling blue or sad and about whether they have lost the enjoyment of things that used to give them pleasure, called anhedonia. These two simple questions together are very sensitive for screening depression. Further evaluation would be necessary because they're not specific to depression. Not surprisingly, work-related injury was found more often with men with repetitive tool use and women using vibrating tools and working with arms above shoulder level. Thomas et al. Evaluated the prognostic value of baseline data compared with the prognostic value of intervention. Each of the following independently reduced the likelihood of recovery: being female, reporting a gradual onset of shoulder pain, and having a higher baseline disability. There was general agreement among all the guidelines that the physical examination is not able to clearly distinguish among shoulder disorders, however, is able to rule out serious disorders. We reviewed the literature for questionnaire performance and compatibility. The following are recommended: Disability of the Arm, Shoulder, and Hand Scale or DASH, Shoulder Pain and Disability Index or SPADI, American Shoulder and Elbow Surgeons Standardized Shoulder Assessment Form or ACES. Our group felt that the easiest to use in practice was the SPADI. Many practitioners use the Cyriax approach in evaluating movement and in-play responses for the shoulder. Well, disappointingly, Hayes et al. Found that the tissue tension approach by Cyriax applied to the shoulder had very poor interrater and intrarater kappa values. Better values were found for the knee. Let's talk about impingement syndrome. In the PARC study, 913 patients underwent physical examination and diagnostic arthroscopy. Each of the tests used did not do well alone. However, the results indicated that the following cluster was of value. The combination of the Hawkins-Kennedy, painful arc, and infraspinatus muscle test yielded the best post-test probability of 95% for any degree of impingement. Here are examples of two of those tests. Well, what about rotator cuff tears? Well, the combination of the painful arc, drop arm sign, and infraspinatus muscle test produced the best post-test probability, around 95%, for a full-thickness rotator cuff tear. Well, now let's enter a more difficult area: instability and labrum tears. A systematic review by Loom et al. Attempted to determine the value of 6 tests commonly used to evaluate instability and/or labrum tears. Results for each test are listed here. You can see the likelihood ratios and confidence intervals for each. All seem to have reasonably good likelihood ratios. However, note that the confidence intervals for the biceps load test 1 and 2, and the pain provocation test of Minori, and the internal rotation resistance strength tests have very wide confidence intervals, calling into question their value. The apprehension, clunk, release, load, and shift, and sulcus signs proved less useful. The researchers conclude that results should be cautiously interpreted because studies were completed in select populations in orthopedic practices, mostly assessed by the test designers and evaluated in single studies only. No accuracy studies were found in history-taking or clinical tests in primary care in this study. We often use pain location as an indication of a potential source of damaged tissue. Well, how valuable is the location of pain in making a diagnosis of a specific structure in the shoulder? In a retrospective study by Ito et al., common sites of pain were evaluated using clinical charts of 149 patients diagnosed with either rotator cuff tears or adhesive capsulitis confirmed by arthroscopic findings. The authors conclude that pain location is not useful in locating the site of a tear. However, the physical exam based on positive results to muscle tests with appropriate thresholds for muscle weakness was clinically useful. Note that this is a study of pain and not tenderness locations. The lateral and anterior shoulder were the most common sites of pain, regardless of the existence of whether there was a tear or where the tear existed. Motion pain was more common than pain at rest for patients with rotator cuff tendinitis or tears. The value of muscle testing certainly varies based on which muscle. You can see here that the most valuable is for the supraspinatus. The full can test and empty can test showed the highest accuracy when assessed with muscle weakness than when assessed with pain. You can see slightly less value for the infraspinatus and subscapularis. So let's summarize the key ratings for the in-office evaluation of the shoulder. We gave a rating of A for the use of questionnaires because there is strong evidence to suggest that for shoulder function questionnaires, small sample sizes in most studies make conclusions difficult. The DASH is commonly used and has a good rating on systematic review. We gave a rating of A for the physical examination. There is strong evidence that clinical tests for the rotator cuff are able to rule out full tears. They have questionable value, though, for partial tears. For instability and labrum tears, the evidence suggests that tests have moderate sensitivity and specificity, but the quality of studies are still questionable. For range of motion, evidence indicates moderate reliability. There is moderate evidence to suggest that the use of Cyriax testing of the shoulder has been shown not to be very reliable. Let's move on to radiography. We reviewed the American College of Radiology guidelines for the appropriateness of radiography of the upper extremity, which included the shoulder. This and other documents support the use of radiography for primarily bone-related conditions, including, of course, suspicion of fracture, dislocation, infection, and tumor. All guidelines reviewed indicated that radiography is of little diagnostic value for the evaluation of soft tissue disorders unless there is an acute traumatic presentation. But what about diagnostic ultrasound? Some chiropractors are trained in the use of diagnostic ultrasound or refer for its use. In a Dines et al. Review, the authors felt that given the low cost, diagnostic ultrasound might be the initial choice for detecting full thickness and partial thickness tears, keeping in mind the caveat that the accuracy and reliability are operator dependent. Also, the practicality may be a factor, with most orthopedists insisting on MRI. Well, what about diagnostic ultrasound compared to the standard practice of ordering MRI? Ardick et al. Evaluated the value of MRI and diagnostic ultrasound for soft tissue disorders of the shoulder. They found a high sensitivity for ultrasound in detecting rotator cuff tears and 100% sensitivity for biceps pathologies. The Dines et al. Review concluded that there was a high sensitivity for full thickness tears. However, for partial thickness tears, the pooled sensitivity estimate was much less. For magnetic resonance arthrography, there was high accuracy for full thickness tears. However, for partial thickness tears, it was less consistent. In the Ardick et al. Study, MRI was superior to ultrasound for glenoid labrum tears and subacromial bursal effusion hypertrophy. Although this was an MRI versus ultrasound study, clinical findings were measured. There were more correlations between clinical and MRI findings versus clinical and ultrasound findings. The severity of disability measured by the DASH questionnaire was associated with either subacromial bursal effusion or labrum tear on MRI, and clinically with restricted shoulder extension. The more painful shoulders had more frequent findings of glenoid labrum tear and more restricted extension. Subacromial bursal effusion hypertrophy was correlated with shoulder disability and positive impingement test maneuvers. Now, this is important because we often focus on the rotator cuff, in particular the supraspinatus, when we consider impingement. Clinical tests as a whole had modest accuracy for detecting rotator cuff tears and biceps pathology. Now we move on to management, and we'll start with manipulation of the shoulder. The literature on manipulation for the shoulder is both sparse and complex. Most studies that use the term manipulation are utilizing what chiropractors would consider mobilization. A literature search for mobilization and manipulation of the shoulder produces results that include manipulation under anesthesia for adhesive capsulitis. And that's the vast majority of articles, and studies that address not only joint but soft tissue mobilization and manipulation. We did not include manipulation under anesthesia in our rating process. Well, due to the fact that most studies involve mobilization and not manipulation, we felt the need to list our specific recommendations regarding high-velocity, short-amplitude adjusting, and we list our contraindications and yellow flag cautions for some of these scenarios. Most of these are obvious, but let me address a few. For all patients, an evaluation for joint stability must be performed. Based on the findings, it is recommended that no HVSA manipulation be used for patients with medical subluxation, hypermobility syndromes, or gross looseness, including multidirectional instability. Mobilization, such as applying a load and shift or Maitland grade 1 through 4 type of translational movement, may be appropriate in these case settings. For patients with adhesive capsulitis or any acute inflammatory condition, such as rheumatoid arthritis, active hemarthrosis, or extensive swelling, rheumatoid variant disease, crystalline disease like gout or pseudogout, or acute bursitis, it's recommended not to use HVSA. There is some literature evidence that aggressive mobilization may worsen or prolong the natural history of adhesive capsulitis. Based on this evidence and the experience of our panel, we feel that an HVSA approach is highly risky for certainly the early stages of adhesive capsulitis. For the middle and later stages of adhesive capsulitis, chiropractors should consider a progressive application of increasing the grade of amplitude of manipulation. It's recommended that by using patient feedback and response as a guide, increasing grades of amplitude may be applied. For patients with impingement syndrome with a known structural cause, such as a type 3 acromion or osteoarthritis, we strongly recommend that any HVLA manipulation not be applied in a superior direction. Our team gave a rating of B for mobilization and for HVLA adjustments of the shoulder. There is moderate evidence that mobilization not including grade 5 Maitland or cavitation may be of short-term benefit and limited evidence for long-term benefit for patients with shoulder pain, and there is fair evidence for the use of HVLA adjusting of the shoulder girdle. In the following slides, you'll see some of the studies upon which the team made their recommendations. You can see, for example, in the Winter et al. Study at 5 weeks, 70% of the manipulation group considered themselves cured compared to only 10% of the physiotherapy group. In the Conroy study, there were improvements in a mobilization group compared to a comprehensive treatment group that received stretching, exercise, and soft tissue mobilization. Let's now discuss the evidence for the use of exercise in the management of shoulder pain. In the Ludwig et al. Study, male workers diagnosed with impingement syndrome were randomized into either an at-home exercise group or no treatment control group. The intervention group showed significantly greater improvements in the shoulder rating questionnaire and shoulder satisfaction score compared to the control. 2 RCTs by Jin et al. Indicate some benefit to exercise or equal benefit compared to other treatments such as corticosteroid injection. An RCT by Howard et al. With 90 consecutive patients diagnosed with impingement syndrome were randomized into a subacromial decompression surgery group or an exercise group. The exercise prescription for each patient was directed towards strengthening and decompression of the shoulder with emphasis on parascapular muscles and rotator cuff muscles. The frequency was 3 times the first 2 weeks, 2 times a week for the next 3 weeks, and 1 time a week for the remaining 7 weeks. Outcomes were measured using the constant score and pain and dysfunction score. The authors concluded that subacromial decompression was not shown to be superior to physiotherapy with exercise. Here's a very interesting and highly rated study on ultrasound and calcific tendinitis. Ebenbichler et al. Used consecutive patients with a diagnosis of calcific tendinitis type 1 and 2 who were randomized either to ultrasound or sham ultrasound. Improvement was seen as early as 6 weeks. In 6 of the shoulders, 19% calcium deposits had resolved. Calcium deposits resolved in at least 50% in 9 shoulders. At 9 months, 9 shoulders, or 42%, had resolution with improvement seen in 7 shoulders. Our ratings for exercise and ultrasound were a rating of B for exercise for rotator cuff disorders and impingement syndrome, and a rating of A for ultrasound for calcific tendinitis. There is moderate evidence that exercise may benefit patients with rotator cuff disorders or impingement syndrome. There is limited evidence that eccentric exercise may be of benefit for patients with impingement syndrome, and there is strong evidence that pulsed ultrasound is useful in resolution of pain and calcific deposits for patients with calcific tendinitis. We now move on to the elbow. Remember that lateral epicondylitis is the only elbow-associated condition with any evidence available. Even though LE is also referred to as tennis elbow and does account for between 75 to 80% of the 50% of recreational tennis players who complain of lateral elbow pain, tennis players account for only 5% of all LE patients. By far, the most commonly reported causes of LE are in fact work-related. 35 to 61% are related to work and 27% with leisure activities. 30% have no known precipitating cause. Lateral epicondylitis is seen more often in individuals between the ages of 40 to 60 with an equal distribution between men and women. It appears to be self-limited, with a reported duration per episode of between 6 months and 2 years. And note, unlike the shoulder, there were no clinical studies found on the diagnostic accuracy or reliability for the clinical examination of LE. We found the literature evidence for manipulation in LE interesting. The literature includes studies on both local manipulation and mobilization of the elbow and non-local manipulation for lateral epicondylitis. The non-local manipulative approaches include cervical and/or cervicothoracic spine manipulation and manipulation of the wrist. The systematic reviews by Schmidt in 2003, which included all physiotherapy approaches, concluded that there was insufficient evidence for mobilization techniques, specifically for the wrist for LE. The systematic review by Bissett in 2004 indicated that there was some evidence that local manipulation may have an immediate effect. However, the study was a single treatment approach without follow-up. In this study, there was a substantial increase in pain-free grip during treatment using a lateral glide mobilization or Mulligan-type treatment approach. Patients were randomized to a lateral glide treatment group or a position-only group. As mentioned above, the study only indicates the immediate effect, but had no follow-up to determine how long effects lasted. Two studies involving cervical spine manipulation and mobilization were evaluated. An RCT by Vincenzino et al. Utilized a lateral glide mobilization at the C5, C6 vertebral segments. This small study of 15 patients demonstrated significant improvements in pain threshold, pain-free grip strength, and pain scores relative to placebo or control. There was no measure of duration of effect through any short-term or long-term follow-up. Our ratings for manipulation and mobilization for LE are a rating of B for mobilization and a rating of D for HVSA adjustments to the elbow. There's moderate evidence to suggest that mobilization of either the elbow, cervical spine, or wrist may produce some immediate effect, but no evidence for or against long-term benefit. There is no evidence for or against high-velocity short-amplitude adjusting of the elbow in the management of LE. So, now on to exercise for LE. In the Bissett review, he included a follow-up prospective study by Penmaki et al. In an RCT conducted in 1996. The exercise utilized in this study consisted of a 4-step exercise for 8 weeks with a 36-month follow-up. The exercise group improved more when compared to a pulsed ultrasound group with lower pain scores on a visual analog scale. Now, one should question whether pulsed ultrasound is a sham approach in this study or whether it is considered a standard for the treatment of LE. At the 3-year follow-up, the exercise group had pain scores and pain drawings that had improved significantly more than the ultrasound group. 5 patients in the ultrasound group had resorted to surgery, whereas only 1 patient in the exercise group had surgery. Ultrasound and other PT approaches were evaluated in a lit review by Schmidt. Only ultrasound demonstrated a clinically and statistically relevant positive effect, although the evidence was rated as weak. They did conclude, though, that one study determined that exercise was significantly better than ultrasound combined with friction massage. Bracing is controversial, as shown by several studies. In an RCT by Struis et al., a brace-only group was compared to a combination group that received physiotherapy. Interestingly, at 6 weeks, physiotherapy was superior to brace-only for pain, disability, and satisfaction. However, the brace-only group was superior on ability to perform daily activities. At 6 months and 1-year follow-up, there were no significant differences between treatment approaches. Now, this reminds us to always determine whether short-term success is actually what we're after. In other words, quicker improvement has value, even if time evaporates that difference. A more recent RCT by Faze et al. Used a specialized dynamic extensor brace, custom made for each patient. They compared a brace group to a no brace group. Brace treatment resulted in significant pain reduction, improved functionality of the arm, and improvement in pain-free grip strength. After the treatment period, the brace group maintained beneficial effects at a 1-year follow-up. Now, this was a customized brace, so extrapolation to other bracing approaches is not possible, although it's interesting that the extension braces that used to be prescribed for carpal tunnel syndrome have had some reported success anecdotally for LE. Here's the team rating for exercise, ultrasound, and bracing. Now, as a group, the rating was C. Chiropractors should consider the use of exercise in the management of LE, and there's limited evidence for the use of physiotherapy approaches, with some possible short-term benefit for ultrasound and bracing. Finally, we arrive at carpal tunnel syndrome, CTS. The prevalence of CTS is not entirely clear. The range is from 3.7% to as low as 1%. Certainly, in some high-risk populations, this percentage is higher. So what are some risk factors? Well, I'm sure you will immediately suspect keyboard or mouse usage, but let's look at that assumption. Atroci found that obesity is associated with an increased incidence of CTS. They found that women in their 40s and 50s are 4 times more likely to suffer from CTS than men. Confusing the identity and therefore management of CTS is the variable and unpredictable course. Some studies indicate a cyclic, unpredictable occurrence of silent periods alternating with periods of exacerbation, and other studies indicate spontaneous improvement without any management. Recent studies contradict the assumption of a causative relationship to keyboard use. The evidence points to a combination of highly repetitive work or in combination with forceful work and work involving hand and wrist vibration. Specifically, risk is high for work that demands intensive manual exertion, such as automobile assembly workers, meat packers, and poultry processors, but not necessarily frequent computer users. There's no literature evidence at this time between posture and CTS. Let's look at the value of the history and exam for CTS. Darcy et al. Performed a systematic review of history taking and physical examination for diagnosing CTS and used electrodiagnostic testing as the comparative standard. In the studies that met the inclusion criteria, the following were indications of the value of history and physical examination findings confirmed by electrodiagnostic testing. You can see decent positive likelihood ratios for the following: hypalgesia in the median nerve territory, classic or probable cat's hand diagram results, and weak thumb abduction strength. So you may ask, what's a cat's diagram? It's simply a drawing with different numbness paresthesia areas outlined, which include either typical CTS or median nerve areas versus others that are not median nerve areas. Now, findings arguing against CTS that have decent negative likelihood ratios were an unlikely cat's hand diagram result and normal thumb abduction strength. Some standard tests, such as Phelan's and Tinel's signs, thenar atrophy, and nocturnal paresthesia, had little or no diagnostic value when compared to positive electrodiagnostic test findings. Electrodiagnosis is often used to confirm CTS, so how good is it? A sensitivity and specificity analysis was performed in a study by Liu et al. In 2005. Specifically, short segment onset latency transcarpal mixed nerve conduction velocity yielded the highest sensitivity at 75%. Our rating for the examination for CTS was a rating of A. There's strong evidence that the standard clinical examination tests used for CTS vary in their ability to rule in or rule out CTS if electrodiagnosis is used as the gold standard of comparison. There is mild evidence that if electrodiagnosis is not used as a comparison standard, the sensitivity and specificity rise to a usable or valuable level. Now, there's only one RCT for chiropractic manipulation in CTS. Davis evaluated chiropractic management versus usual medical care. Even this study is not specific to manipulation or adjustment of the wrist, including manipulation of the spine as part of the overall management. In both Cochrane reviews on conservative management of CTS by O'Connor and Verdugo, the Davis study was included. However, the conclusions reached were inconsistent. The Davis study, in fact, indicated that in the short term, both approaches were essentially equal. The improvement reported was in perceived comfort and function and nerve conduction and finger sensation overall, but no significant differences between groups. In the Davis study, medical treatment consisted of medication and nocturnal wrist supports. Due to the fact there was only one RCT for chiropractic management of CTS, our rating was both B and C. There is limited evidence from one moderate quality RCT to support the use of chiropractic multi-therapy approach to CTS that includes adjusting of the wrist and cervical spine. Our group's expert opinion supports the use of adjusting of the wrist, most often the lunate and distal radial ulnar joints, for CTS. Night splinting is a standard approach for CTS, so let's look at the evidence for that. The findings in the Verdugo systematic review are similar to other reviews such as Gerritsen, Darcy, Forenstein, and RCTs such as Gerritsen's that indicate outcomes that favor surgery. Gerritsen's RCTs indicate that at the end of an 18-month follow-up, 41% of patients in a splint group had eventually resorted to surgery. However, in this prospective evaluation for splinting, Gerritsen et al. Found a 31% success rate for splinting. Only 2 prognostic indicators were identified for patients with both a short duration of CTS complaints, a year or less, and a score of 6 or less for severity of paresthesia at night at baseline. The predicted probability of success was about 62%. Now, the percentage of patients correctly identified by this method was high, at 78%. Now, all studies indicate some success in the short term for some patients. A more recent RCT by Werner et al. Demonstrated not only significant decreases in discomfort and symptoms, but also maintained the success at a 1-year follow-up. Now, the weakness of this study was the high dropout rate of 30%. What about ultrasound? In the Goodyear-Smith systematic review of non-surgical management for CTS, they conclude that Ebenbichler and Ostis studies provide conflicting evidence with a high dropout rate. They summarize, stating that there is limited evidence for ultrasound in the short and medium term. A more recent study supports this finding. Real briefly, here is what our team determined from the literature regarding some other approaches such as B6, yoga, and laser. For B6, 2 RCTs on the effects of 10 to 12 weeks of vitamin B6 therapy have been evaluated. There is limited evidence for improvement of finger swelling and movement discomfort with 12 weeks of treatment. However, there is also limited evidence that B6 does not improve any of the symptoms or signs of CTS. One study by Garfunkel et al. Evaluated yoga stretching compared to wrist splinting for CTS. There was limited evidence that yoga improved pain and Phelan sign findings better than wrist splinting. There was evidence that yoga and wrist splinting were similar. There is limited evidence that low laser therapy treatment has not been shown to have an advantage over a sham laser treatment. However, more recent studies, not included in this review, seem to support laser therapy. To summarize, our rating was C for the use of splinting and bracing, and C for no evidence for B6, yoga, or laser. There is limited evidence that splinting may be helpful in the initial management of CTS for patients with a new onset of symptoms, and there is no strong evidence for the use of B6, yoga, or laser therapy, and there is no convincing evidence for or against myofascial approaches for exercise or stretching. I hope this brief review highlighted clinically useful information for your management of upper extremity disorders. More research is needed, but there is clearly some helpful support for many of the diagnostic and management approaches used by chiropractors, and some indication of certain evaluation and management approaches that are of less value. I do invite you to review the full chapter on the upper extremity and the other chapters at www.ccgpp.org.